I'll go to the topic for today, that is AOX. Dr. Chaudhary's hand is risen. In case he wants to say something, you can please talk. So coming to the background, as you know that more than 8 million babies have been born in the world by IVF, and the live birth rate is somewhere between 19 and 22%. To an egg, what we can do to its mitochondria, ATPs, what we can do, what we are doing, is it correct? Is it, can we do the number, gentlemen, ladies, that we have pro-oxidants, body reductase are in the body, and they are enzymatic oxidants. So we can have non-enzymatic, and this is lying in the follicle. It can be into the fallopian tube. May undergo atresia, apoptosis. They have got very important function. As I told you many times, the main job of cells of granulosa is what can someone keep in our mind as we are moving ahead, and they will all lead to infertility. It can be primary, it can be secondary. But PCO, we use multiple drugs, and the very good drugs are berry seeds and a lot of things people give. So IVF and IUI, metformin has got no role. Metformin and all the things will occur in the body, and then we have activated macrophage, the peritoneal. There is atresia occurring. We knew that the follicles can be of poor quality, but today I want you to go to the level of 𝐂𝐴𝐵 and melatonin and try. Coming to poor ovarian reserve. When the number of eggs are more, we are not bothered. When the number of eggs are less, we are bothered. But when the woman's age is young and AMH is more than 1.5 or 2, number of eggs are less, we are not bothered. That egg may be the golden egg, so we are not bothered about this. But when, as we move ahead, this is an ideal situation in a young girl coming to us at around, say, around 36 years of age. Her AMH is 1.5 and she's got a poor ovarian reserve on ultrasound. We are sure that she'll have a good egg because she's young. She's not aging. Aging is the main problem which generates ROS. But same woman after 38 years, when we get, even if AMH is good, there's a chance that she'll have a poor quality egg. So this is how we have to see how our eggs are behaving, and why is this topic important for us? Why did I pick up this topic? There's also one more aspect of this topic, is that we've spoken about PCOS, we have spoken about endometriosis, we have spoken about overall stress, lifestyle disorders. We can also have DOR due to multiple other reasons. So age of marriage can be late. A woman is not responding to hormones. We have tried that before. She wants to undergo egg freezing. She wants to primarily she wants to get married late. She wants to come for an egg freezing. The reasons can be religious. All these things are leading to, and the women are trying to grow nowadays. They want to empower themselves up now, and they're getting married late. They want to get a good job, stabilize, then they get married. So now many of the marriages are becoming unstable. So the women are getting married late, they are having unstable marriages, divorces are going high, and with everything occurring, one thing is for sure, which I'm noticing nowadays, that these initially, some time back, women were happy with donor cycles, but nowadays the type of people we see, they all want their own children. So I made this term called rebound matritva. This change I'm finding in past 2 to 3 years. Women are taking more control of their life. They say, doctor, what if I am 40? I want to have my own child. They don't talk about donors. That's the most beautiful part of IVF now, when my average age at our clinic is more than, or 40 is average age which I see. So they all want to have their own babies. AMH maybe 0.5, maybe 2 follicles. They'll say, okay, do for me 2 cycles, 3 cycles. You do segmented IVF, but I want to have my own baby from my own eggs. So I'm calling it rebound matritva. So this is what happens in the woman as she's aging. multiple things are happening. Embryo quality is going down. So these all things, I want you to keep reading these things. I won't go through them. But important is that finally we go down to the level of egg. Egg is contained in a follicle. The follicle has got two layers. The inner layer is called granulosa. The outer layer is called theca. The two cell theory is being happening there. It all works upon the FSH has to work along with the androgens, basal level of androgens, and they work with small spikes of LH. So in case both the compartments are not working due to ROS being there, or in the egg, when the mitochondria they stop working, then all these things will start occurring. Like in the men, we are finding low sperm count now. Same way in the women, we are finding low egg count. And why is it occurring, we don't know. But probably the stress is leading to the damage to the follicular apparatus. So these are few things which lead to poor follicular genesis and poor egg quality. Ovarian reserve is falling down over period of days, as we are aware of, 20, 30, 40. Primordial, primary, secondary. This we have spoken large number of times in our classes for every batch. This is my favorite topic, in fact. So I keep talking to all of you. Just know that we have got pre-enteral phase and enteral phase. And this is when we start doing our ultrasound. Till this part, we have got AMH, and this part we have got inhibin B. So I've covered it many times. I won't talk about this. Inhibin B and FSH have some sort of dependence. And then here also we have dependence of with androgens also. This we have to know. So these all things, they work together and they make the follicle grow. So they can have a cavity, they start making aromatase, they start making androstenedione. All these things are occurring at this point of time. Something goes wrong, then the whole pathway goes bad. Again, similar picture. You just wanted to tell you that how AMH and inhibin comes together and work. Now, coming to follicular genesis, as you'll find that initially there is no theca. Theca comes after some time. So we have something called theca recruitment factors, which comes along with LIF. Initially, we have a single layer of granulosa cells in the around the egg. That's called a primordial follicle. And later on, theca will start developing. And for theca will develop, theca will have vascularization, theca will work under LH, and theca will help the body making androgens and estrogens, and later on even progesterones. So theca cells have to grow properly. This is a very important factor for us, and they have to make limited androgen. Limited. In case they make large amount of androgen, like in PCOS, we've got a problem. To make a limited amount of androgens, they have to make. This is important for us, and so all these activations occur in the body at various points of time. We have activation of the follicle growth occurring at very young follicle, the egg size, then theca recruitment is being done, and then theca cells, androgens coming, ovulation occurring, corpus luteum forming, then forming progesterone. So this is what the whole thing happens. All the signals are moving in the body. No theca, it cannot make steroids, as you can see here. Then the primordial follicle will give signal to the egg to start making theca cells. Initially, they only have granulosa, but now they'll develop theca. It'll go into two cell theory now, and then it'll form receptors. It'll start making androgens. It works under LH, makes a corpus luteum, and gentlemen, ladies, everything here is under effect of small amount. Your theca recruitment can be defective. So for that, we start giving the patient DHE. So there's a basic philosophy of giving an hormone. This is what I want to discuss with you today. Next, I think 15 more minutes, then I will, his time is 9:40. What do oocytes need to grow? How to grow an oocyte? They need ATP. They need pro-oxidative stress, and they need ovarian androgens. So we have already covered all these three things in short for you. Let's see now. They require ATP. ATPs, they are formed in the mitochondria. Mitochondria have got the mitochondrial DNA, and a lot of things are there. From ATP starts from air, from where the ATP synthesis will start occurring along the crista of the mitochondria, and then it will need CoQ for this, CoQ10 for this. So when the CoQs are coming and the follicles are forming, and the CoQs are coming and the ATP is forming, it will give strength to the spindles of the chromosomes. In case the CoQs are not there and the mitochondria are not making ATPs, the strength of the fibrils which hold the chromosomes will become weak. As a result, the chromosomes become weak and they don't divide properly. It's very important for us to have good levels of CoQ10 and ATP in the body. And for this, we have to energize the mitochondria. So we start giving mitochondrial energizers, which we give in the form of CoQ10 and sometimes as a melatonin. So these all are the chromosomes. In case the spindles they go bad, then chromosomes will follow. These are the chromosomes as we find here. These are chromosomes are here. In case the spindles go bad, then all the spindles will start breaking or they'll become sticky everywhere. And then we'll have aneuploidies and we have recurrent implantation failures. So this is what we need. We need basically ATPs, CoQs, cell division, basal amounts of DHEA we need in the body so that things go in the right direction. These three drugs about which we talk very frequently, I'm going to cover for you in around 5 or 10 minutes. We have DHEA, melatonin, and CoQ10. These all we are using nowadays. We use quite a lot, though we don't have much of evidence, but we are using. We have some papers here and there only. We hope that they'll supplement the embryo quality and have a final better outcome. CoQ10, some people use CoQ10 100. I use CoQ10 300, also use 100. So CoQs are required for the ATP synthesis as we have covered. And then just remember that this is the function of CoQ. The function of CoQ. I want you to take a pause of 10-15 seconds and read this slide. इसे एक बार पढ़िए अपने आप से, and then I will move it. So we need CoQs. CoQs are important and they restore normal energy in the body and they protect the cell from the oxidative stress. Okay, good. And the coenzyme Qs are they are like the energy currency of the cells. You know, they are the battery of the cells and they make the cell work better. They are like vitamins and they are primarily present in the mitochondria. And it's a dietary supplement, so you can use it. They are oil soluble, and this is what they all do. So 95% of energy in the body which we generate occurs with CoQ10. And in case we give somebody CoQ10, in that case, the energy will be generated very quickly and we'll have better outcome. So we'll have these many things. We have improved QR, the oocyte number reserve can increase, quality can increase, ovarian response can increase, number of cumulus cells will increase. So I like to ask you one thing, or tell you one thing, that till now we've never bothered about the cumulus cells, but they are the ones which are important for us. Remember, two things are important. One is the cumulus cells. These are the basically cells which are they are the ones which have high energy biosynthetic quotient. They're always growing. Then we have granulosa and then we have theca cells. They're very important for us in infertility, but about which we don't talk. Then we have endometrium. So all these things they do well in case we give them CoQ10. So multiple studies have been done with CoQ10 and placebos. I'm not going to talk about studies, but rate of aneuploidy and clinical pregnancy rate has increased by some studies. So I'll take a pause of 1 minute here. Let's go into the hand raising mode. How many of you of all my friends, 154 are present now, I can see on the screen. How many of you are using CoQ10 in your practice? Just raise your hand. I use.
Female infertility. I use in both.
Both, correct.
Male infertility. I use in male infertility.
Quickly,
I
quickly.
also use male infertility, sir.
Thumbs up,
And
thumbs up, thumbs up,
aged patients.
thumbs up, thumbs up. I want you to click thumbs up on your screen in case you can learn. So I know how many people are using. Wow, 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 wow. Great, great, great. मजा आ गया. It's really good to see you people here. अच्छा लगता है संडे के दिन आप सबसे मिलके. I miss my classes with you. As the badges go off, today we are starting with E9 and E8 will get over in I think by this weekend. Good memories. Great. So we are using 𝐏𝐭𝐤𝐿. We use 𝐏𝐭𝐤𝐿. Great. Melatonin. Melatonin is a new drug. The new drug, and many people are using melatonin. I use melatonin quite a lot. So, comes from the pineal gland. It's a very broad spectrum antioxidant. It'll just destroy all the oxidation. ROS, it'll just destroys it and gets killed in root while it is destroying. So it's called a suicide antioxidant. ये चार चीजें करता है. These four things are being done by melatonin. These four things it does, and it works pretty well. And thoda expensive, but it works pretty well. So it is the most important antioxidant in the ovarian follicle. Does not promote oxidation under any. It just stops oxidation from occurring. So it works pretty well, and it works along with vitamin C, vitamin E, and glutathione. And it will, as I've told you, it won't only work along with enzymatic, but also with the non-enzymatic antioxidants. It will enhance them. देखिए, synergy है, enhancement है. This thing is not found in the other antioxidants. They work independently, but here it will synergize them. So it will work along with glutathione, peroxidase, superoxide, SODs. These are the non-enzymatic. These are the enzymatic antioxidants, and synergy with vitamin C, E, and glutathione, which are the non-enzymatic antioxidants. So that's the way it works pretty well. And these are few things which they talk about melatonin. Male infertility, I'm very happy. It can really do magic once in a while. But even female infertility, multiple papers are coming. It helps in reducing the follicular stress. So it works pretty well. And as we spoke about PCO, melatonin comes in the follicular fluid. It's very high amount in the follicular fluid. And they help us in fighting the oxidative stress and by having oocyte maturation. Okay. So melatonin is a wonder drug. In fact, it's a wonder drug which people are claiming. Though I'll come to Cochrane also very quickly. So in case you look at all these things, they will protect the oocytes. This is a scavenger. It will scavenge everything which is present around. It will reduce the DNA and lipid damage. Give you a better quality of luteal phase. So everywhere, wherever it goes, is going to help you. So melatonin is a good drug, and melatonin receptors also. Amazing. DHEA is a good compound. We are using it from a long time nowadays, and these all things it will do: increase ovarian reserve, increase ovarian number, the oocyte number. It may increase the AMH, augment IGF-1. So multiple things. So it is the best compound presently, though it lacks data itself, but the best compound to do going for ovarian rejuvenation. Many people go in for PRPs and multiple things, but this is one thing which will lead to ovarian rejuvenation. This is about DHEA to talk about. DHEA, most abundant sex circulating, comes from adrenal, since it is from cholesterol. And then just remember that DHEA will start getting low with the age. As somebody will age, the DHEA will come down, and DHEA acts somewhere here. It will act somewhere here, and it will act somewhere here and help the follicle to grow. And you'll find that synergy between FSH and androgens. So DHEA will supplement these androgens. So in case we give it to them, they will help in recruitment of more number of follicles, increase the AMH values, and it will help them in selecting a good dominant follicle here. That's about the DHEA. And DHEA, in case you look at what all it can do, this is what DHEA can do for us. Levels of AMH can go high. Here, I'm not repeating anything. I've just, what I could get, I have written here. All these things DHEA does, it helps primarily here and primarily here. And here they work on the follicular wall. So 75 milligrams a day is one drug which we use, and that's the DHEA. It will reduce the pregnancy rate and reduce the aneuploidy rate. What's new or kya hai hamare paas? What all new we have? I've spoken about these three things which we had. I've spoken to you about melatonin, DHEA, and 𝐂𝐤𝐿s. They all work pretty well. 𝐂𝐤𝐿s are in the dose of 100 or 300 units. Melatonin is 3 or 6 milligram, and DHEA I normally give 75 milligrams per day. That is SR, or you can give 25 milligram TDS. It can does all those things to improve our outcome. Now coming to one last slide, which I borrowed from a pharma company, is about uterovaginal environment. The whole environment, we've spoken about PCOS, endometriosis, unexplained infertility, but there is something called the uterovaginal environment. And here we have the role of NSE, N-acetylcysteine, we have arginine. So multiple things which people are also using. So NAC and astaxanthin. Astaxanthin many people use. Here it works here. How it works, we are not very clear, but it works pretty well. Many of those tablets come with all these compounds bundled up. They contain NAC, arginine, astaxanthin. So they add calcium. They add calcium here. I'll just few lines about L-arginine before I end. L-arginine is could you please switch off? Yeah. So the endothelial cells are responsible for making nitric oxide. So nitric oxide is important because nitric oxide will lead to vasodilation. So the endometrium lining can increase, and nitric oxide can act upon the L-arginine. So nitric oxide synthetase will act upon L-arginine to make nitric oxide. So in case we give somebody arginine, then we hope that there is enough nitric oxide synthetase present in the body. So we'll have more vasodilation and we'll have a triple layer endometrium. Just keeping that in mind, we use a lot of L-arginine in the people. L-arginine is a staple drugs which we are using now. And L-arginine is to some extent also recommended to improve the endometrial lining. That's the way the L-arginine works. It will increase blood supply to the genitals. It can be given to the male also. So that's about L-arginine. And so in short, in case you look at the L-arginine summary, it can improve the cervical mucus secretions. It can improve for us the endometrial thickness. It works pretty well. And this is in short the summary. The oxidative stress is good. Pro-oxidative stress is good. ROS is bad. Pro is okay. But pro is internal. It's basically for cell division. And in case we have oxidative stress coming in large amount, it will lead to like inflammation. It can affect every part of the body. And look at the gray hairs coming. It's all due to due to oxidative stress. As aging occurs and we have gray hairs, we get wrinkles on our face. Whatever Botox you may put, it doesn't come back. That's the way the life goes on. And just few words from antioxidants for female subfertility review from Cochrane. They compared the drugs. Standard treatment is 1 milligram of folic acid. And they started to compare with other drugs. And they wanted to see how it works in the patient. And they were all minerals and vitamins. They're all antioxidants. So they used the following drugs. They used the combination of antioxidants like N-acetylcysteine, melatonin, L-arginine, myoinositol, carnitine, selenium, vitamin E, B complex, C, blah, blah, blah. They use nearly everything. And they wanted to compare which one works better. So they had a low quality evidence. Evidence is there, but low quality evidence that the woman, in case woman uses antioxidants, the subfertile woman with an expected clinical pregnancy rate of 19%, the rate among the women using antioxidants is around 25%. So from 19 to 25%, the clinical pregnancy rate can go. This is what they say. And but this is a low quality evidence. Second is that when they compared melatonin, they compared low dose and high dose. This was, as far as I could make out, 3 and 6 milligram. So they found that once they use melatonin, so when compared to the high dose of melatonin, between 12 to 40% and around 24% with low dose melatonin. So in case we increase the dose of melatonin, we can get a higher pregnancy rate. But I think we have to still wait the low quality evidence. But one thing is for sure that melatonin is being considered by Cochrane. Melatonin, they have not ruled out completely. So keep your eyes and ears open for melatonin, ladies and gentlemen. Is one drug which may help us tomorrow. And low quality evidence overall. Low quality, the conclusion that taking an antioxidant may benefit. It's low quality evidence. No evidence of increased miscarriage, multiple pregnancy, but evidence. So it doesn't cause any harmful side effects. It doesn't cause any harmful side effects, definitely. And it's got limited evidence in support of doing something positive. It won't harm, but may not help. So that's about the author's conclusion. And then I've also referred to the BFS policy. I have referred to the HFEA guidelines. Nearly all the guidelines in the world I have seen. To summarize, that is always a balance between, I've told you, balance between POS and the antioxidants. But when it becomes ROS goes very high, the balance will tilt. Then there's a problem. And normally these things are very important for a woman. ROS is important so that the eggs can work better. There can be better endometrial changes, folliculogenesis, ovarian pseudogenesis can occur, luteolysis, menstruation. So these are common things. They should be occurring. So when the levels go very high in endometriosis or PCOS, the balance tilts. Then we have problems occurring in folliculogenesis and also the mitochondrial activity. So they say that for PCO patients, the drug advice is N-acetylcysteine, NAC. NAC is one drug which people have been using. And it helps in giving insulin more sensitivity. So NAC is one drug which people recommend. NAC and 𝐂𝐿 is one drug which people recommend in patients who are having PCOS. And then this is about the PCOS, and coming to the endometriosis. Multiple drugs have been tried, but here again, I think 𝐂𝐿 is a good choice in case you want to use, but curcumin, melatonin, catechins, these all people are using. We have to wait. We have to wait and see which finally turns out to be a good drug, but till that time, we don't have any answer. And for unexplained infertility, we tend to add a lot of selenium. Selenium is good. Selenium is good, which can be safely added. And here they said after 8 months of treatment, they used selenium and they found the result. This paper is from Cleveland, and it can also help us. The vitamin C and vitamin E can also help us in preeclampsia and other bigger diseases. The antioxidants like melatonin, omega-3 acids have been investigated for preventing recurrent pregnancy loss, but we still await the right answer. I think that's it. Thank you so much. And I've spoken for around 1.5 hours today, and I'm open for any queries. I'll stop sharing my screen here and we can all talk for a few minutes. If you have any queries, we can talk. Akriti, I'm done.
Thank you, sir, for this beautiful session. Now, I would like to invite, I would like to welcome any query from the audience.
Sir, you talked about melatonin, sir. You give it in combination or in isolation? It comes in a combined formulation, and it also comes in isolation also. Like,
Yeah.
how do you give it, sir?
So, Parinder, when I use it in when we use it in male infertility, we use it in a combination. Carnitine, we use carnitine and we use melatonin. And when we come to the female partner, here again it's a combination. We use it. What I use is DHEA plus melatonin. So 75 milligram DHEA plus 3 milligram of melatonin.
And sir, you talked about CoQ10 for female. How do you give it, sir?
CoQ10, in case you take a combination, you have to take, it's available as CoQ10 100 or 300. I normally prefer 300. I don't know why I prefer it, but I prefer 300. So CoQ10 100 is a lesser amount, 300 is a bigger amount. You give it in any dose. Once you use CoQ10, people use it twice a day. I use it single dose a day. But CoQ, use it in any dose, any number of tablets. But important. But CoQ should be not given in the night time, because CoQ is a mitochondrial energizer.
Okay.
It's an energizer. Because a woman takes a CoQ or a man takes a CoQ, men also take a lot of CoQ. They're awake the whole night. So they get energized. They feel very light and happy. They like to watch TV. They'll put on Netflix and disturb the wife or the partner. That's what happens. They सोता ही नहीं है, तो laptop खोल के पूरी रात पढ़ता रहता है. That's what ladies say. Tell me, my husband has stopped sleeping. He'll put on his laptop in the night and start doing his. So there's a problem with CoQ. So CoQ 100 is okay, but CoQ 300 whenever you give from some company, give it in the afternoon or after the breakfast. So the whole day is in activation. In the night he can sleep comfortably. And melatonin, when you take, melatonin should be given in the night time for the men and also for the women, because melatonin will mimic the natural pineal gland secretions, number one. That's number one for the female and the men. And for the men, when we give melatonin, it will mimic his morning erections. So it'll give him morning libido. That's the reason that when we give melatonin to the men, it should be given in the night, so that they are more active in the early morning. That's what companies they claim. I don't know. There is no Cochrane evidence over that, but this is what people come and tell us.
Thank you, sir.
Yes.
Using antioxidants like vitamin E, vitamin D, melatonin, it becomes a big list. So it becomes a large prescription. So how can we reduce that?
Don't prescribe much. First of all, you have to know what you are giving. So giving DHEA to a young girl who's got an average good AMH is not right. That's not right. Should not be giving DHEA to a young woman, number one. Number two, you have to give minimal amount of antioxidants. I normally believe in giving them good diet. In case you ask me, antioxidants are very rich in certain diets also. So my favorite dietary product is, you can give them, what do you call it in your country? We call it amla, gooseberry. So gooseberry is very rich source of all these vitamins and antioxidants. So I like to give them gooseberries. I like to tell them to take a lot of green vegetables, take a lot of chocolates. They are very good and my favorite is actually fenugreek, methi ke beej. I don't know whether it's available out there or not. So fenugreek is my favorite. And then my favorite is goji berries, which I write quite a lot. I somehow don't like writing, and I give them a lot of raisins and honey. Raisins and honey, they're full of antioxidants, but they have to be prepared. You don't give raisins and honey together. You take some walnuts, you take some raisin and honey, and keep them in the refrigerator for 24 hours. And then there's a time when they become activated as per the Ayurvedic principles. So I give a lot of these drugs. I somehow don't like to prescribe a lot of these sort of drugs because they're expensive and not many people can afford it also. But when I have to give, I am fond of melatonin I'm fond of DHEA, and I'm also very fond of CoQ10. I do give. But it's not that for every person coming, I start writing drugs. I don't do that. They should be earning their drugs. That's important. Fine, Ishri, that's my answer.
Timing of
Thank you, sir.
DHEA, sir?
Hmm?
Time of DHEA, any particular time it should be given?
DHEA is 25 milligram tablet, give it thrice a day. Thrice a day.
It
Or
comes in the dose of 75 mg,
that
sir.
is
And
SR. That is SR. That is SR. What I spoke was a plain, but what you are talking about is an SR preparation, that is the 75 milligram. It comes with plain or comes with melatonin. I
melatonin.
give it with melatonin.
It is to be given at night or morning?
No, you can give it in the evening. That's okay. Anytime you can give it to. But prefer it in the evening because melatonin will mimic your night sleep. That's important. I prefer to give it in the evening time.
The melatonin dose, sir?
Melatonin dose is 3 milligram.
3 to 6.
All the combinations have 3 milligram of melatonin. Some people give 6 milligram. I've got no experience. So I am stuck.
Given in the morning and in the afternoon?
Melatonin in the evening.
In the evening.
That's better because I'm telling you, it'll mimic your sleep cycle. That's the only reason I'm telling.
Evening means at around 7 p.m.
Yeah, you can give. You can give.
Once daily.
You can give once.
And
That's a good
what, sir, and what about the dose of CoQ, sir?
CoQ is either 100 or 300. So a lot of drugs come with 100, where they add NAC, they add DHEA, they add multivitamins, they add selenium, zinc. It's a combination of 100 milligram tablet. You give it twice a day. It's up to you how you want to give it. But I normally prefer 300 CoQ every day.
So dose and duration of NAC?
NAC dose with same to maximum 3 to 6 months, not more.
And dose?
Dose of NAC is, I think,
That comes in 600 milligram.
600 milligram. I think 600. I don't
OT,
remember.
PT?
It is once a day. I give it once a day.
Okay, okay, thank you, sir.
It's a combination. All these drugs like NAC and astaxanthin, we don't use separately. It comes in the drug combination. Everyone gives a different combination.
So NAC comes in the name of Mucinex.
Mucinex करके आता है, but they give it. See, NAC is very good for cervical factor unexplained infertility. It's got a very good action upon cervical mucus. So, but they don't give it alone. They normally give it in a combination. See, what they do is companies, when they make a drug, they put a lot of things in it. They'll put some vitamin D, they will put some selenium, they'll put some manganese, they'll put vitamin E and make a concoction and give it to you.
Yeah.
So I don't use the drug separately. I've never.
So dose of astaxanthin?
I don't know. वो लिखा रहेगा. That's written in the. I've got the. I can just show to you in 2 minutes. But
Okay,
I don't remember because it comes in a combination, and I'm not very fond of. See, I am very fond of few drugs which I use. Just show to you.
Yeah.
I use CoQs quite a lot. CoQ
Yeah.
में evidence है. Melatonin has got an evidence, and then I use DHEA.
Yeah.
So other these drugs I don't use myself. I don't use, but companies are making, and you can use in case you feel like. But these.
So in which group DHEA should be used? In मतलब which age group?
No, DHA का age group नहीं होता है. DHA का whenever the AMH is falling low, when the AMH is falling low and the number of X are falling low, then you start giving DHA. DHA is an follicular energizer.
Yeah.
Fine. And your CoQ is an mitochondrial energizer.
Okay.
So we give CoQs, we give DHA when we feel that the follicles are not healthy.
Yeah.
Giving to a young girl, PCO patient, DHA has got no role at all. It won't work.
Okay.
So in case you get a young girl who's got PCOS, and you want to give her some antioxidants, and I think it will worthwhile giving her CoQs.
Okay.
Not give her DHA. So we have to learn what to give where.
Okay.
Give them a powdered concoction of multiple drugs. Okay, people give. You can also give, but I don't give. So all these, the कितना होता है वो लिखा रहता है उसके ऊपर.
Okay, thank you, sir.
Okay.
Arginine, you were telling, L-arginine, you were saying you give arginine for endometrial receptivity.
Ma'am, arginine comes in sachets.
Yes, sir.
They come in sachets. Arginine comes in a sachet of. They come in a sachet with sugar free also.
Right.
200 milligrams sometimes. So they come in different sachets, and they normally when they come to you, they इसमें एक चीज खाली याद रखिएगा कि arginine sachets can be when you buy them, you can also buy them when they don't have sugar free. They make it sugar free. So many people are when you give them an option, because arginine is very sugary. Both carnitine. Remember, we give Maxoza in case you give to people. Is any one of you using Maxoza here?
Yes, sir.
Yes, sir.
How do you
was
feel about Maxoza? How do you feel about Maxoza?
Excellent, sir.
No, but I have started just 1 month or 2 months back, so I have no result.
Maxoza is a good drug. It's a recommended drug. So remember that Maxoza will come as a 3-gram package, and arginine comes in a say 5-gram package. So these are very sugary. बहुत मीठी होती हैं. One sachet is coming to at 40-50 rupees. Fine, and it's so sugary that people don't take it. So diabetics को जब भी आप देते हो sachets, they normally come as an orange flavor or strawberry flavored. Both Maxoza L, Carnitine L, and arginine, which comes in a 5-gram granule sachet, they are very sugary. So be careful when you give it to them. You have an option of giving them sugar free. So
sir, I want to add something.
Bolo, Alpana.
Good morning, sir.
Good morning.
I have done a thesis on the NASH in the PCOS patients, and even the 600 of the DD. It comes in the market by the Cipla and the Lithium company, Luminax and the Misinax, and it is a good. Even the infertility in the IVI has worked.
So what is your outcome? What is your outcome, Dr. Alpana? We are from a medical college. I think you can definitely tell us.
Yes, yes.
Yours will be, I'm sure it will be quoted in by Cochrane also, your paper.
Not the Cochrane, but some Indian journals we have published.
Tell us about your experience.
Yeah, cycle regulation was very good, and the acne was good, and spontaneous conception rate in the IUI cycle after the 6 months therapy was good.
Acha, okay. And how long were you giving it to the people?
So for 6
total कितना दिया आपने?
600 mg BD.
Dose is 600 milligram OD or BD? You give BD.
BD, we have the
BD. Fine. So the NSE, your normally NSE is recommended is till around 1 gram, 100 milligrams per day. It is recommended. So you give it 600 milligram BD is okay. So 1 gram is the dose of NEC approximately. Fine. So you recommend to people. You got some recommendation.
Even I have done the study on the DHES also, sir, in the premature ovarian reserve, and the result was not very good in the infertility, and only 30 patients. So
that's what I'm saying. That results are still.
Was
so I'm just going by the Cochrane. I just sum up by the Cochrane. Results are not there, barring arginine. Arginine 6 grams per day. Arginine has some benefit. CoQs have some benefit, and melatonin has some benefit. All of the drugs are very low evidence, so I really can't talk about them.
Sir, even done the thesis on the vitamin D in the PCOS, and we measure the level of vascular endothelial growth factor, inflammatory marker, before the therapy and after.
How was it?
And vitamin D really works very well, sir.
Wow.
And but 85% prevalence in the PCOS was the vitamin D extent.
Correct.
Even hypertrichosis of the ovary and the acanthosis also resolved after the 6 months therapy of the vitamin D.
Very right. It's a great input. Vitamin D is very important in PCOS. We all give vitamin D in PCOS. You can give vitamin D. You can add. So a lot of people give myoinositol and dichloroinositol. Ratios can be 40:1 or 19:1. So multiple things are there. But I think vitamin D has got good evidence in cases of PCOS. I fully agree with you.
So what should be the duration for vitamin D? So 8 weeks will suffice, or can you go beyond that?
We don't have any answer. But I think to suffice or not, you have to check their levels. आपको check करना पड़ेगा. Which I am a bit chary.
So serum level should be followed every 4 weeks or 8 weeks.
नहीं महंगा पड़ता है ना. One test is costing ₹15. So I am very chary about telling them to do the test. Initially, I was doing it for a couple. They spend
Okay.
rupees 3,000 before, 3,000
Yes,
later.
sir. It's very
So no, I
costly.
don't do it. But I give them a packet of sachet of whatever they want to take, open market, take that for 8 weeks, come back, and we do their case. But in case I get a failure with me, previous IVF or previous recurrent abortions, there I do confirm that vitamin D is okay. And many times you have to give 6 lakh ka lagana padta hai, vitamin D3 ka shot lagana padta hai. But for an average person coming to me with no prior failure, I don't check it.
Okay.
That's my
That's
experience.
something
So
else.
people
That
cannot
means it
afford.
has to be
People cannot
individualized as per
afford.
the case.
Yeah, correct. This is anybody's choice. Anybody's choice.
Sir, one small doubt here. Sir, hello.
Yes, yes.
Yeah, one
Yes,
small
sir.
doubt here regarding this vitamin D, because you mentioned as 6 lakhs. Because I've seen people giving 60,000 IU every week, and I've seen people giving 6 lakh injection also.
Yeah,
So
6
what
lakh
he prefers?
No, it builds up the reserves very quickly. See, this is not meant for IVF. It doesn't help. It's not the right thing for IVF. What many people give. See, when people come from abroad, we get a couple coming from some country, and they they have to undergo a case. Then lot of noise.
Yeah, sorry, sir.
So in case you want to treat them, they got low vitamin D. Vitamin D is taken in nanograms and in picomoles. I'm sure you're aware of that. So in nanograms, cutoff is 30, and picomoles, in case I'm not wrong, the cutoff is 75. 75
Yes,
no?
sir.
Millimoles, picomoles. Huh? So in case vitamin D is low in a couple coming from abroad, there is no time. They only come for, get their visa, come for 15, 20 days. Then what do we do? We can't tell them to take. We got a lot of people coming from Middle Eastern countries. You know? The vitamin D is low, so we give a shot of 6K, and vitamin D shoots up. But that is not the right way of management. I think we should give them, gradually build up the vitamin D and do it. But again, there is no comparison over these things, which is better. But 99% of we prefer to give vitamin D 6,000 and not 6K. So there is nothing hard and fast written here. So we can't give you any why, which is better, why is it better? But these two options are there. When somebody is in a hurry means you have to go back. Somebody comes to you from Riyadh or Qatar. I have Muscat. I don't have any choice. I have to do that like that only. Okay.
So 6 lakhs is one injection is enough. One single injection enough.
Yeah. It builds up the reserve within 10-15 days. Reserve ठीक हो जाता है.
For 1 month, one injection.
But गिर भी जाता है. I just found that I have so many couples when they come next time for their embryo transfer, your vitamin D is low. So vitamin D is a big issue in our country. Big issue of the worldwide. Sometimes I feel that the values have been kept deliberately low, or what has happened to vitamin D, because we never heard about vitamin D deficiency back 5 or 6 years. So I've never found anyone who has got good vitamin D. Maybe they'll come to you in an Audi or a Mercedes or a Ferrari. Vitamin D has to be low. I don't know why.
Because we measure vitamin D3. Is there any relevance between D3, D2?
No, D3
what do you see?
We measure D3. We measure D3 only. We don't measure D2. Okay.
So as per the IOM guidelines, we have to give the maintenance dose of the vitamin D after the initial recovery phase for the deficiency. Should be for the 2 years. Once a sachet of 60,000 in a month for the 2 years.
That's what I'm saying, that the people are on continuous vitamin Ds. In case I told you in the beginning, patient comes to me and I give them vitamin D and patient goes off. They go to somebody else. We will again start. So people are on lifelong vitamin D nowadays. But vitamin D is one thing. Just remember that vitamin D and TSH has to be kept in view. These two are the main enemies which we have. And prolactin. Prolactin you may ignore in case there is no galactorrhea or there is no irregular periods. But vitamin D and thyroid, you have to keep a watch.
If it is in combination with antioxidant like 𝐏𝐭 and multivitamins as a 400 international unit daily dose, then also we have to give that weekly. No.
We are talking about building the basic reserves by giving D3. We are not talking about the daily supplementation. The daily supplementation, when we give somebody of vitamin D, or say we give somebody calcium, there's a different issue. हम D3 की बात कर रहे हैं.
Okay.
We are giving injectable form. We are giving oral or injectable form. So as Alpana brought out very nicely that the guidelines say that it is lifelong. You said, Dr. Alpana?
Sir, 2 years. It has written
2
for the
years.
2 years.
2 years. And then how do you manage after 2 years? After 2 years you are checking the levels of vitamin D3, or you just let them go.
It is not mentioned in the guidelines to check it for the deficient person, but in some other guidelines they have say you have to take it lifelong on the interval of 2 months, 3 months.
Correct.
And they are not mentioning about the checking of the levels after that.
Anyone?
They become.
Sorry. What does the Foxy guidelines say? Has anyone read the Foxy guidelines? I think that may give you some answer. Because we normally see patients for 2-3 months and then they go off. But what does Foxy guidelines say? Maybe someone who's doing gynecology here can guide us better.
Sir, ideally we give sir. Once a week for 8 weeks, then once a month for 6 months.
Correct. So 6 months, 2 years, lifelong. Anyway, I think you can keep giving it as per your own experience. But vitamin D should be supplemented. This is the most important thing, is that vitamin D should be supplemented, and you can follow whatever guidelines you are following. The right guidelines I should also read should be from Foxy. I'm sure they'll be there for our subcontinent. I'll read them today and put them in the group. Akriti, you can note it down. Vitamin D supplementation from Foxy guidelines. Group mein dalna nikal ke. We'll discuss.
Yes.
Great. I think I'll beg your leave. I've got an embryo transfer back at 11 o'clock. And we have covered that topic. With the aim was to give you some very basics of the subject, how it works. I didn't go to much of the pharmacopoeias. Pharmacopoeias, you know better than me, because the pharma keeps telling you, and you follow what you want to follow. I've given you the molecular levels where they're required. This was my endeavor. So I hope it has benefited you. And sometime we'll sit and talk about male infertility also. In male, we have got a lot of concrete evidence. You'll enjoy that more than this. So with this, in case somebody, I'll send you the reference articles. After the lecture, I have to go for an embryo transfer. I've got a couple of OPD patients. In the afternoon, I'll send you the things. And we are meeting for PCOS. Yeah, we are meeting for a PCOS thing now. The next curtain raiser.
Yes, sir. Next curtain raiser is going to be held on 2nd of January, and the topic is PCOS.
Correct. So we'll cover everything again. But today, Akriti, find out about vitamin D and D3 supplementations as per Foxy guidelines.
Okay.
Okay,
Thank
guys.
you, sir, for
Bye. Take
us
care. Bye.
on this topic. Thank you. Thank you, everyone. Thank you, Dr. Kaur, ma'am.
There is Dr. Parvinder. She has to submit up. Madam, actually, I'm getting call. Patient is getting ready. Dr. Parvinder, sorry, I just forgot. I'd like you to summarize the session.
It's lovely session, sir. बहुत सारी information मिली. Very lucid information. Very, very nice session, sir. We had great time, and we are looking forward to your next session on PCOS.
Thank you, ma'am. Bye, everyone. Take care.
Thank you so much, sir. Thank you. Thank you so much.
Thank you, sir.